Good evening, everyone. This is the next in the Royal College of Surgeons of Edinburgh webinars, really aimed at trying to bring the college to you on a Monday evening. This evening's webinar is going to focus on the remobilisation and the reconfiguration of surgical services in the post-COVID era. We have four participants for the webinar this evening. We have Tracy Gillis, who is the Medical Director at the NHS Lothian and has got a background of general surgery. Good evening, Tracy.
Hello.
We've got Mr. Nigel Mercer, who's currently the President of the Federation of the Surgical Specialty Association, and he's got a plastic surgery, cleft and palate background. We've got Mr. Ian Sharp, my colleague from University Hospital Birmingham, where he is the Medical Director for Operations. Lastly, probably quite well known to a lot of you, we've got Professor Rowan Parks, who's the Acting Medical Director for NES, for Education Scotland. So without any real further ado, the four participants are going to show a brief slide set to set out their thoughts in relation to the remobilisation and reconfiguration of surgical services. And I think, Nigel, you're going to encourage our colleagues and people on the webinar to maybe think about the bigger picture. Think, what is it you think you said to me? Think beyond the end of your scalpel. So, correct. Nigel, the screen is yours. Thank you.
Thank you very much indeed. Okay, this is the FSSA. It comprises the 10 surgical specialty associations, and we have the Association of Anaesthetists who are invited members as well. So, what are we really talking about here? And this is the paper from the Lancet from the 29th of May, which showed that if you are unlucky enough to catch COVID in the 2-week period perioperatively, you do have a significant chance of dying. This was a big study, lots of different patients, both elective and emergency, and obviously that is quite a worry. And we now are focusing more in the British Isles on 14 days of self-isolation, COVID negative swab 72 hours before surgery, and then 14 days of self-isolation after surgery so that we don't become COVID, our patients don't become COVID positive during that pathway. And to date, we've had a national perspective on what should and shouldn't be done. And certainly within NHS England, that national perspective seems to be just losing some focus. So, what's the problem? Well, health professionals, we're used to going to hospitals, and we're used to the fear, and we're used to putting on, donning and doffing our PPE. PPE now seems to be much less of a problem than it was. But actually, if you look at behaviour in hospitals, the social distancing is very poor. We've seen Weston-super-Mare and Kettering and other hospitals where the numbers of staff are the major problem. And as a result of that, the patients aren't avoiding hospitals like the plague, they're avoiding it because of the plague. And the GIRFT have looked at the waiting list in London, and 45% of patients on the existing waiting list for eye and orthopaedic surgery have elected to come off the list at this stage, because they don't want to catch COVID. So we need to think about that very carefully when we're thinking about restarting services, because if we can't restart services in COVID-like facilities, we really are up the gun tree. And one of the problems is our patient population, and this is from the Journal of Clinical Ethics in the last week or so. And patients do rely on the internet for a lot of their information, and there are loads of different guidances out there at the moment, and patients, I think we can guarantee, probably won't be reading them. They'll be reading what happens from the internet. So just to look at the law a wee bit, I actually have a law degree, and we have to bear in mind that if someone dies of COVID in the perioperative phase at an inquest, that could be designated as an unnatural death by the coroner, and that could lead to a whole world of pain for the unit where it happens and for the surgeon and surgical team and everybody else. So we have to really take this seriously. People are saying, well, of course, I can do my operations easy, straightforward, no complications. Well, we all know that's not true. Every operation has a complication rate. Now, these are the 6th of June prioritisation sheets from 1A in the top, it has to be done as an emergency, down to the large sheet in the bottom, which is to be done after 3 months. And if we, deliberately, you shouldn't be able to read those. But if you look at these, there are 400 different cells, each with different procedures in. And so there are several hundred cells or procedures that aren't being done at the moment. And it's estimated, as you can see there, that there are hundreds of thousands of missed operations, tens of thousands of missed cancers. And that 12 months to recover is now looking more like 24 months, if ever. So the FSSA produced the guidance about what to think about. No need to dwell on that. And basically, as surgeons and as all healthcare professionals, we have a moral responsibility to consider if a limited resource can be used for someone in greater need. And that surgical care needs to be delivered according to the regional and national need and to match resources. And really, even as we go into recovery, there should be some prioritisation to make sure that the appropriate healthcare resource is being used for the best good for the public. And we felt very strongly at the start there should be no distortion of the principles. So theatre usage we know is down. I'm sure that'll be covered again, so I won't go over that. But we have 50% of the throughput, and if we have COVID-like facilities and COVID-negative patients, then we can get up to near where we were before. But we're not going to reach the same productivity that we did before. So what we've got to think about in terms of consent for this, I think on the end of the operation, is that the Montgomery ruling has not been changed by the COVID crisis. And we know that perioperative infection is bad news, but also there are fundamental changes in the surgical pathway, and every surgeon who's planning recovering their surgery practice at the moment has got to think about this, particularly if you're in private practice, because it doesn't happen automatically. Same with the anaesthetic teams, they need to be very careful. We need to understand what's going on with them, and there's a material risk from the changes they've had to bring in because of their techniques being different, although merciful heavens it seems as though drugs are probably okay at the moment. That's part of the material risk the patient needs to know. In the post-op period, what discharge planning is required? If someone's got to self-isolate for 14 days, who removes the stitches? Who does the physiotherapy? Who looks after them? Who provides their needs and their return to hospital? That may actually change your outcome. And again, that is a material risk, and the patient needs to know, because if they don't, they get a poor outcome, then I'm afraid it's the surgeon or the doctor who will be up before the court for Montgomery failings. And so there are no longer any minor complications. Everything is going to be a hassle. And there are the unknown uncomplications that have been coming out during the COVID crisis. And there is a lot of work being done now, which is being done extremely well. And we're gradually building up a picture of what can and can't be done at the moment. But at the moment, these complications are hard concepts for patients to understand. And no one should be expected to sign a blank check for their recovery. So this is also important. We can't be held to account because of the failings of the health service to provide care at the moment. That's well covered. But basically, if we're not appropriately consenting our patients, we are really going to be for the high jump after this. The lawyers are already circling over this. So we need to think about online consultations. You think about reputational damage if patients develop complications which weren't dealt with properly, and the fact that the press will be out there to get people if there are mavericks doing things they shouldn't be doing. So we have a big problem. We're now looking down the barrel of a gun of an enormous number of patients waiting for surgery. It looks as though private sector is being let off the lead a little bit, and we may be seeing cosmetic surgery being restarted in the next few weeks in the United Kingdom. And I think we all have to ask how appropriate that is. This comes from the NHS Confederation from the 10th of June, just a week ago. And I think the very bottom line there is we are definitely looking at the R word, and that is the rationing word. So whilst Mr. Hancock says that's where we are, perhaps that's what we're staring at.
So thank you very much. That was very, very thought-provoking. Just before we move on to our next speaker, it's very pleasing to see that we've got almost 200 participants now on the webinar, so good evening to you all. I don't know if you're all aware, but there's a question and answer facility available on the webinar, and you can post your questions. And what I will try to do is to get as many of these questions asked as possible during the course of the webinar, but please submit your questions. We've already got some that were pre-submitted, but we're looking for a healthy, vigorous discussion. So again, I think, Tracy, if you don't mind, if we could move on to your presentation. Tracy, I think you were going to talk about the past, the present, sorry, you're going to talk about how to approach this across the whole of the system of the NHS. So, Tracy.
Yes. So I was really planning to cover some similar things, but from a perspective of a medical director in a relatively big integrated system, which is covering primary care, mental health, as well as secondary and tertiary services. So in terms of, we have used some language that allows us to describe priorities across our whole system, so including primary care and mental health, but which are very applicable to surgical services. And so we've called those cases where we think there's cancer or a suspicion of cancer, cases that are clinically urgent or have become urgent through delay, and cases where we believe that deferral would cause detriment. And we've wanted to pick that one up, particularly partly because we cover mental health and also children's services, where we obviously could see very significant detriment for children across a long time if there was delay. We've noticed very significant changes in referral patterns with a reduction in almost all referrals. And similar to the concepts that Nigel explained, we've really tried to encourage people to concentrate on the changed perceptions of acceptable risk and make sure that those are really well explained to the patient and their family and across the wider surgical team. And that family involvement is very important when we've had such an absence of visiting, because it means that it becomes even more important to make sure that the patient has passed on concerns and what's been covered in the consent process to others in their family. We all know that we're all pretty poor at remembering to document what we've explained to families, and we've updated our patient information to cover some aspects of this. I think for us, diagnostics is a real potential for a bottleneck in all remobilisation of services, and we need to make sure that we keep enough capacity to concentrate on completing the assessment and staging of cancer patients. And to that end, we're looking really carefully at our data to see whether we have essentially got missing cancers from the numbers that we would expect to diagnose. And this is some really early data coming through. You can see that the number of lung cancers that we've diagnosed in the month of May is down against May 19, as you would expect. But there's a suggestion in that there's a change in the stage that we're seeing. So that will be very important for thinking about potential outcomes. On the right, you can see incomplete data as yet around colorectal staging as those cancers have come through. And again, we're about 25% down on those numbers. But making sure that we've kept enough diagnostic capacity to put patients who might be presenting later or through less usual pathways through a staging process is very important. When it comes to thinking about the perioperative considerations, I think there is something really important for surgeons to consider about who they're working with in that wider team. Are you working with a wholly reformed and rested team, or are there key members who are still redeployed? Or are you working with people who are working outside their usual areas of practice, either in theatre or in the wards? Because we know that that whole team dynamic is really important as a consideration for outcomes. And many people have not had much rest after what we've been through. And so whilst we need to make sure that we do remobilise as quickly as possible, we need to be thoughtful about the implications for staff. We are just a little bit thoughtful about our perioperative complications. Where we're seeing those happening, they seem more obvious, and that may be for a number of reasons. One would be there's a loss of that more routine activity in the denominator, so any complication that does happen is attached to a more urgent case. We need to think carefully about whether, as part of the run-up to post-operative care and the 2 weeks of isolation, patients are potentially becoming physiologically a bit more impaired, and that might be impacting on their outcome. And then there's really the aspect of the whole team in terms of making sure that that's not just the availability of PPE, but actually the physical and the communication barriers and impacts that that causes. Finally, in terms of thinking about the post-operative complications, I think what I really want my surgical teams to be doing is thinking about the whole system. So what you see on the right is the example of our daily dashboard. The detail isn't important, but you'll see that it gives you a sense across all areas of the system, how many primary care referrals there are, how many people are being seen in the hub, what the geographical distribution for us looks like, and in particular, where we've got any staff outbreaks. Because I think understanding what environment are you bringing a patient into, is there any chance of nosocomial acquisition, is really something that you'll want to communicate well to patients. And I have to say, most nosocomial acquisition in most systems is probably happening based on staff-to-staff transmission. And that is an issue because staff understandably perceive patients as a risk, they perceive the public as a risk, but they don't perceive each other as a risk. And I think that is really a feeling that has been, they've been something that they've been through together, and so they're a team bonded together, and they forget to distance from each other in non-public facing areas. So thinking about discharge, Nigel's touched on this, how easy is it for people to be seen post-op, and how will you make sure that those plans are properly discussed is something that we need to concentrate on. And I'll end it there, thanks.
Tracy, thank you very much. Again, very thought-provoking. So I think if we can, we'll move on to our third speaker. I'll ask Ian Sharp to make a few comments. Ian, I think you're going to refer to what we used to do, what we're having to do, and what we might have to do in the future from an operational view. And if you could also give a perspective on the size and the nature of the organisation that you're responsible for this remobilisation and reconfiguration. Thank you.
As Tim has mentioned, I'm coming at this from an operational perspective as the one of the senior team responsible really for our response to COVID and subsequent challenges. And in the early days of COVID, I picked up the baton to try to oversee our elective care programme, and have carried that on now into remobilisation. So just briefly, UHB is a large tertiary secondary care provider across 4 sites in the centre of England in Birmingham, over 2,500 beds, 70 theatres normally, and 22,000 staff. And as many will know, we in the Midlands saw a fairly large impact, and as the main receiving hospital really for the whole of Birmingham and Solihull and parts of the West Midlands, we have seen a very major impact from COVID. In total now, I think we're over 3,500 cases, but the nice part, and I've deliberately included it, is that we've discharged successfully 2,500 of those patients. So I think it's important to reflect on that and to acknowledge the positive good that has come out of the redeployment and the change that was necessitated as a result of this disease. So our current inpatient load is about 105 inpatients across the sites, but at our peak we were up to 166 ventilated patients in our ITU, which was twice the normal size of our ITU stock across all our sites. And at a peak in terms of inpatients, 740 of our inpatient beds were occupied by known positives, and then there was another, the similar size number of suspected cases. So like everybody else, we did the obvious things. We took down the elective programme, and I remember reflecting on the 16th of March, just as it was announced on the BBC News, that within a month, the NHS would be taking down its elective programme. I went home that day, having been told that ours was ceasing the next day. And of course, that gave us the opportunity to prepare, and it also gave an impetus to our work in terms of liaison subsequently with the independent sector. And as you can see, we've been reasonably successful in terms of how we've managed that over phase 1. Over the last 10 weeks, we've delivered a fairly high volume. Without that, we would have delivered almost no cancer surgery at all as one of the largest cancer hospitals in the country. So this really has been a lifeboat for us over the past few weeks. As well as that, internally, we've managed to sustain something of a transplant program, and I'm pleased to be able to say that we've delivered 40 plus liver transplants in this time and have had no positive conversions in terms of COVID. So we were really pleased to hear that news, because that gave us great confidence when it came to actually planning for phase 2 and for establishing clean pathways. So one of the things we had to do very early, and you've heard Nigel and talk about this already, was to identify ways of prioritizing cases appropriately within specialties and between specialties. And really, we've relied very heavily on the FSSA intercollegiate guidance for doing this, and have built on that and modified it very slightly for our internal range of services. But really the document stands, I think, and has been, again, a really useful benchmark for us all to work from. But as well as that, we had to take into account very early on the likely increased risk from COVID, both in the pre and post-operative phase, and have had to adjust to some extent our individual risk assessment processes around pre-screening and prep for all of our elective surgery. So that's what we had to do through phase 1, and we've tried very hard to learn from our experiences during that time. And as we move now through into phase 2, our response was really targeted at setting up clean or green or COVID light. I'm not absolutely sure what the correct term is for this, but anyway, let's say COVID light streams of work, using prioritized waiting lists, accepting that some elements of this workload will probably just have to wait for a while, but that we really do need to focus on delivery of urgent care as effectively as we can. We have implemented a screening process and protocol, which is very similar to that is in place across the country, and has been, I think, quite difficult for many patients to accept. And we've certainly experienced large percentage refusal rates in a number of our specialties, even with patients who are listed for cancer surgery. And that was a bit of a surprise, but I suppose, as Nigel has said, with the fear in the population currently, we perhaps shouldn't be as surprised by that. I would echo Nigel's comments about consent, and it was pretty clear very early again that we had to modify our consent processes, and we've taken the step to certainly raise awareness in all surgical specialties of the need for the change in the risk envelope for elective surgery to be taken into account and adequately and appropriately discussed with all patients going through any elective pathway. And I think, reflecting on the comments that Tracy's made, one of the challenges for us, of course, has been to start to work effectively across the whole system, which is something that in England, of course, that's very variable in terms of how effective that's been. We've worked with colleagues in secondary care at the Royal Orthopaedic Hospital and at Birmingham Women's and Children's Hospitals to try to take a more system-wide approach, both for consistency and equity across the piece, but also to try to utilise what capacity is available to the best possible effect. And to do that effectively, we also have to work and still have to do the work with our CCG and primary care colleagues in terms of demand management, referral modification, agreements about diagnostic thresholds, and so many other things that really now have to be taken on board and developed pretty quickly if we're going to address the need in the population. So just from a pragmatic operational perspective, just to describe what we have done, and I apologise, I've just spotted a typo in my own slides, but at the Queen Elizabeth Tertiary Hospital, we've had to take a decision to try to deliver a volume of elective care that can only be delivered through that hospital. So that is transplantation, that's also major cardiac, thoracic surgery, vascular surgery, upper GI cancer, etc., etc. So complex ITU-dependent tertiary level surgery. We've separated flow for patients by taking our ambulatory care centre out of use and utilising that as a separate entrance with appropriate screening and testing at the door, with a clean pathway then into our theatres, utilising 9 of the 23 theatre block as clean theatres with appropriate staffing, and then moving from there along one seamless flow through a PACU that we've had to set up completely from zero. We didn't have a PACU because we had a relatively large ITU footprint previously and could use that for HDU. Now, given that part of our ITU is allocated to COVID, we've had to step back from that. We have a clean ITU for level 3 care, but we have a PACU for a lower level of post-surgical care. And we've also established mixed specialty working across our 3 large inpatient surgical wards on the 7th floor. So we've taken a whole floor of our hospital with a clean lift and a clean pathway through that hospital to try to actually keep this area as clean as it possibly can be. And I think we're helped in that regard because we have a relatively modern building with great airflow, with a high percentage, something like 45% of our rooms were side rooms before we started. And so clearly that helps. And I think that's something that people do need to take on board in terms of planning what they do. So that's the tertiary end of the market. But our other plan, which we started late April to think about this, and we've implemented this with a go-live date of the 8th of June. We're now into our 3rd week in this facility. So Solihull Hospital, which was previously a mixed, relatively small general hospital, we took the decision, and I think it was quite a brave decision, to make that a completely elective site. And so we closed the medical investigation unit, and so the minor injuries unit and the acute medical unit by the 25th of May, which was not without some pushback, as you can imagine. But that allowed us to then clean and remodel the hospital estate to give us clean pathways for access and for discharge, and allows us to utilize those 8 theatres on that site, along with a newly developed PACU and 230 inpatient beds, to deliver a significant volume of elective surgery. And as well as that, we're able to deliver cardiology investigations, some dermatology, ophthalmology, and endoscopy. And that's because the hospital is on 2 floors, and basically clean surgery is on the upper floor, and the slightly possibly less clean or less stringent pathway through our cardiology, dermatology, and ophthalmology goes through the ground floor to a large extent. So by taking an approach to work ahead, to plan intensively, and I think I would say to take the largest reconfiguration exercise that the Trust has ever seen and to deliver it in 5 weeks was an enormous challenge. And it really has required mobilization of the whole workforce towards that task. But having done that now, we're starting to see patients accepting that they can be admitted through a clean path, and they will accept offers for care. And so they're turning up, and I'm pleased to say we're successfully treating patients so far, without causing any major comorbidities. But clearly that remains a risk, and there are a number of issues that require ongoing monitoring. Thanks.
Well, Ian, many thanks for that. And I can vouch to our over 200 participants the amount of work that has gone into that. I think what's particularly sort of interesting or noteworthy is that we've come up with a series of solutions that actually fit the Trust, and the fact that the Trust is on 4 sites, and you've got different divisions scattered across those 4 sites, and it's very much a bespoke solution for our individual trust. So thank you very much for that. Rowan, maybe if I could just ask you to comment. There's, as I say, over 200 participants now are with us, many of whom will be trainees. What do you think we should be doing about realigning training with this remobilisation and reorganisation of elective surgical services?
Okay, so the trainee workforce has been a really important aspect of the whole response to COVID-19. And I guess what I was hoping to show, if I can, all right, is talk just briefly about what was done, the contribution the trainees have made to this response, but perhaps more importantly, what is needed as they move forward. So since April, or before April, a decision was made to pause all rotations to minimise the impact of a lot of trainees moving from one location to another. At the start of April, and indeed throughout May, June and July, there's been no rotation. Literally hundreds, if not thousands, of trainees have been redeployed from their normal training programme to support COVID rotas, work in different environments and different specialties. In Scotland, that was over 750 trainees, so approximately 12-13% of the trainees were moved into a new area of practice, about 1 in 8. So if you multiply that up across the UK, it is thousands of doctors were redeployed. We also had those who were out of programme, doing research or other activities, who voluntarily came back to support the service. And so they've had their research endeavours paused and yet need to get back to them. We've modified our recruitment process. That was vitally important because we have new graduates coming into the system. We need to have people moving out of foundation into core, out of core into specialty training. So there's a real absolute requirement to progress training, but COVID arrived in the middle of part of those recruitment processes. So that all had to be readjusted. And then we have modified how we do our annual reviews to allow a sort of no-fault analysis of what they've achieved to date, and if they were on track, at least allowing them to progress to the next phase of training. So the trainees have already contributed massively. You'll note there's a lot of hours. I'm going to continue that theme just as we think of the restarting and remobilisation of training, because what we need to do is unwind a lot of those redeployed trainees and get them back onto their training programs, get them back into the placements that they were on. And a lot of that is starting to happen. It's happening at different pace in different geographical areas, but we are trying to return them to their at least training program. And certainly from August, there's a 4-nation agreement that we need to restart rotations and reboot not just surgical, but education and training across all specialties. So again, that's a 4-nation decision to try and start rotations in August. We do desperately need to think about how we realign education and training in the workplace, because that is the core element of how trainees develop and progress. So workplace training has to be realigned with the remobilisation of clinical services. But we do then also have to think about how we deliver that education review, how it can be delivered. We base a lot of the education and training on regional teaching days, on face-to-face activity. And there's no doubt, at least in the short term, we're going to have to be innovative and think of new ways of delivering that education. Undoubtedly, there will have to become a much greater reliance on online education and how we deliver that, and the staff time from trainers to develop a lot of new material and online activity, and also the place, particularly for the craft specialties of simulation. And that's not just the technical skills, but the non-technical skills. So how do we do that? How can we use simulation, avoiding too much face-to-face and with social distancing? So we have to review how education is going to be delivered, but yet the core of it has to be in the workplace. And I guess more strategically and thoughtfully, we need to consider what aspects of medical education need more fundamental reform. What is the workforce we're training for? What are the requirements in the service going forward? Do we capture a lot of the very positives that have come out of the pandemic, such as the real core elements of generic and adaptability and flexibility in the trained workforce? So that will require some strategic thought to that. So there are some risks in all of this, and risks if we don't consider education and training alongside the remobilisation of the clinical services. There's no doubt trainees have been impacted in terms of their exposure, their experience in what they had been expecting to achieve in the last 3 or 4 months. They may have picked up other new skills which will be beneficial and broaden their horizon. But if we think of surgery, there has been a dramatic reduction in workload and the exposure that trainees have had to develop their logbook and surgical experience. So we have to try and do some form of catch-up. And yet we have to manage expectations, because undoubtedly the rebooting, remobilisation of clinical services will perhaps be not at the pace that some of the trainees or indeed the trainers would wish. So we have to manage those expectations and yet we have to try and get them to catch up. The amendments made to the ARC-P process this year have meant that trainees can carry deficits or competencies that still need to be achieved, but they have to try and achieve those in the next 12 months. And I think there's going to be challenges in that, in terms of what exposure they'll get to surgical and other procedures. But there is a requirement for them to achieve what the regulator, the GMC, has approved as necessary and definite requirements in their curriculum. And at the minute, we have given a 12-month window to allow for that catch-up. There's now hundreds, if not thousands, of trainees waiting to do college exams across the spectrum of specialties. But in surgery, we know there's hundreds waiting to do both MRCS and FRCS exams. So there's a need to get those exams up and running in a safe and secure way, ensuring that either appropriate social distancing or ways of delivering those can be achieved. So that's going to be important. And in the next 12 months, college exams are going to be an important element of what some trainees will have missed out. But the intention of all of this is to ensure we are progressing trainees and that trainees themselves are progressing through training. And the reason that's so important is we have a pipeline coming in. We will have undergraduates graduating, joining the workforce as foundation doctors. We need to make surgery attractive, attract them into core surgical training and into specialty training. And we need to progress them, because if we don't, we're not going to have a workforce. If we delay or extend training too much, there's going to be a huge gap in the CCT holders coming out to supply the workforce in the next 2, 3, 4 years. So there's an immediate issue, there's a medium and longer term issue, which is why it's so important to restart education and training as well as remobilising clinical services. Thank you. So, Rowan, thank you very much for that, and thank you for that, giving the training perspective. I'm very grateful that the panel have been answering almost 20 questions through the question and answer box as the presentations have been getting on. So thank you very much for that interaction. I've got some questions that have come in previously that I'd like to pose to the panel members, and then go potentially to the still open questions that we've got. So the first question really is directed to Nigel Mercer. So Nigel, the question's been put, how we should actually be prioritising surgery and surgical treatment between all the other requirements, demands on our healthcare system at the moment. You mentioned the R word, rationing, but where do we fit, where does surgery fit in the wider picture?
I think one of the issues is that as surgeons, we will always fight our corner very strongly for our patients. I mean, as a cleft lip and palate surgeon, there's been very little cleft lip and palate surgery done over the last few months within the United Kingdom. It's just about starting. But, you know, a cardiac surgeon will argue the same, and Max Fac surgeon will answer the same because of their spectrum. And I think we do need, particularly at the moment, that we seem to have an absence of leadership at the very top of the health service saying, these really are our priorities, this is what we should focus on. And we've then got to juggle everything we do surgically with everything else that's done within our healthcare system and in our social care system. And we know that that's what we do is a really small part of healthcare spending. And as Ian said, getting the hospitals into the situation they're in at the moment was incredibly well done, but actually getting them so that we have a situation where we can do more is difficult. And my own feeling is that the Nightingales should be used as the old-fashioned fever hospitals, if at all possible, because that seems appropriate. And then we need to get our health services facilities back onto some sort of even keel, because at the moment theatres aren't being used appropriately. We're not using the independent sector appropriately. But also oncology's taken a hit, medicine's taken a hit. Paediatrics has almost been destroyed by the problem. And the whole of healthcare is completely in a tumble dryer at the moment, and how we produce those priorities. I think as surgeons, we have to set out our stall, but we do need someone on high to say, these are the priorities for the nation as a whole. It will vary from place to place, but we can put our point, but we shouldn't be shouting others down.
Okay, so that leads very nicely actually into the next question, which is to Tracy. I think this is quite a difficult question, but if you don't mind, how do you think we should be engaging with politicians and the public to look at this bigger, this wider picture, and not just concentrate on the targets or numbers on the front page of the Daily Mail?
Yeah, so I think at the heart of that will be an honest conversation. That we actually have to explain that there are many unknowns for us at the moment, and whilst we can plan and try and put things in place, we need to be honest with patients and the wider public that actually this is difficult and we are finding our way through it. And we need to encourage dialogue between specialties so that we don't end up with the situation that Nigel was describing of people shouting each other down, which we know can happen when people are just keen to advocate for their patient group, which is completely understandable at an individual specialty level. I think as far as the politicians are concerned, we need to reset what normal and safe within an overall hospital environment looks like. And that is not about maximising occupancy and throughput. It is about accepting that if we need to have flow within a system, we have to have some empty capacity to deliver whatever it is we need to do in a safe and appropriate time. I was really interested to hear how Ian had reconfigured those services in Birmingham. We've not been as fortunate in Edinburgh about identifying wholly clean or green sites. So we have to live with a combination within each site. So we have to maintain space in order to move people through without having overcrowded waiting areas or a front door which is bursting at the seams because there's a queue of people waiting to come in. So we have to accept some redundancy in the system to be able to deliver that. And that will be a hard message for politicians because it will not be maximum efficiency.
So I think you're absolutely correct. It's going to be a very difficult message to get across, particularly with the politicians who will be looking for volume of throughput and cost efficiencies because of essentially the financial position of the NHS. So again, that very nicely leads into the next question for Ian. And I ask this slightly tongue-in-cheek, but Ian, how do you deal with and prioritise between the different surgical teams and various personalities pitching for their patients on a daily basis? How do you cope with that?
Thanks, Tim. I have broad shoulders and a fairly thick skin, I think would be the answer. But I some of this isn't new because we've always done it. So, the example of the QE is typical. There has always been competition for the ITU beds, and we've always had sometimes robust conversations about that. So I think everybody realises that these decisions have always been made. But I would echo the point that Tracy makes about honesty and that Nigel makes about clarity on high. The scale of these decisions now is much greater than me having a discussion with either with you and an upper GI surgeon and a liver surgeon about who gets the bed that day, because it's not about individual decisions about a small number of patients. These are huge. The scale is huge, and it is affecting significant volumes of patients every day. So I think without the honesty and clarity higher up in the NHS, I think it's actually unfair to expect individual surgeons or individual medical directors or operations managers to continue to do these prioritisation decisions every day, knowing that there are people that we will actually never get to if we only do the prioritisation the same way that we've always done it.
And if you don't mind, if I could lead into another question, that is, Nigel described the different levels within that FSSA paper, which you referred to and has been incredibly helpful. But how do you think we're going to ever get to the level 4 patients within a reasonable time? Or are we going to say that this is just not going to be feasible within our health system at the moment? I suppose it comes back to Nigel's R word, doesn't it?
I think it absolutely does come back to the R word. And again, I would echo Tracy's comments. I think there is a need for an honest appraisal and an honest discussion with some patients. There are patients on my waiting list who, I'm a maxillofacial deformity surgeon and a cleft surgeon. There are patients on the waiting list waiting for me to operate on them. By the time I get the chance, I doubt if I will still have the skills left in my hands to do the operation. And that is the sad reality, I think, of the situation we find ourselves in. And we do need to have that higher level, straightforward discussion about what can the NHS reasonably expect to deliver. Because I don't think we can expect the kind of financial bailout that we've seen over the past 3 months to continue over the next 3 years. The country probably can't afford that. And unless that's in place, and even if it were, we can't find the staff to fill the theatres, or the theatres don't exist. So I think there's some really tough decisions here. And expecting them to be made on an individual patient basis or even within an individual hospital is I think, a little bit unfair. But whether we see anything on that, I remain to be convinced whether we'll see anything on that.
Ian, again, maybe slightly unfair, but I'm sure people would like to ask you, are you aware of how the trusts, the big trusts particularly, are lobbying centrally to get that point across, which I think we would all agree with?
Well, I am aware, and I know that Dave Rosser, our chief exec in UHB, has almost daily discussions, I think, with Central. And one of the things that's been a big feature of my work over the past few weeks has been the daily reporting to a number of different places within NHSE, often the same information cut 3 different ways in the same day. And I'm sure anybody that's been involved operationally will have been through that experience. And I'll be honest, Tim, I don't mind doing it if somebody higher up the chain is listening to that and will take the necessary steps. I remain to be convinced of that. What I would say positively about the returns that we've put in is we have been invited by Central to really make a wish list of what we think is required in the NHS to help it to recover. Whether that's affordable from Treasury or not, I guess remains to be seen. But I don't think there's any lack of awareness in the higher echelons of the system of just how difficult this is on the ground at this present time.
Okay, I think that's well said. Rowan, if you don't mind me turning to you now, really. Ian touched upon it, and it's pertinent for trainees as well. But what about skill retention or the gaining of necessary surgical skills? How do you think we should be trying to do that, trying to maintain that? And then I've got a supplementary question in a moment.
Yeah, so I think it is an anxiety for some trainees that if they haven't been operating for 3 months, what will it be like when they come back? The reality is a lot of trainees take time out of programme, for example, for statutory leave or for periods of research that are significantly longer, 2, 3, 4 years, sometimes for research. But we have to think about then when they come back, how do they re-engage? How do we get them and their confidence back up to speed? So I think the time interval's probably been okay at the minute. The reality will come when we see how quickly certain surgical disciplines get their workload up. I think certainly my sense, at least in Scotland, is it will be a cautious and slow build up rather than a big bang in any way. So everybody will be vying for whatever opportunities they can get. So I think we're relying a lot on our training program directors, education and clinical supervisors to manage that at an individual trainee level. But a lot of it will be reassuring the trainees that in a complete training program, 3 or 4 months is only a relatively small part, and hopefully we can get them caught up. So I'll leave it there and then wait for your supplementary, Tim.
Well, it's really follows on from that, which is 2 parts really. One is Ian's stated concern about skill retention in consultants and whether they're likely to really be undertaking a larger part of the major surgical procedures to maintain or bring their skill base back up. And the second question really was, do you think that there'll be a need for any curriculum or syllabus review if it's not going to be able, if we're not going to be able to deliver elements of elective surgical training?
Yeah, and that picks up on some of the questions that we've been trying to touch on in the discussion in the chat box as well. A concern from trainees and a pressure coming from management that, to catch up the huge waiting list, the backlog that trainers and consultants need to be doing the operations, as well as the point made about consultants themselves being concerned about skill decay. As I say, if this does progress in the longer term, I think these will become more important, more relevant. In 3 or 4 months, I don't think they're necessarily going to impact too much. But if this whole pandemic in its tail aspect lasts 12, 18, 24 months, then these will be really important considerations. And that's when a whole review of what curricular requirements are necessary, I think might need reconsidered. We've clearly made some derogations for this year's annual review, but with the expectation that those gaps, those capabilities and competencies that haven't been achieved at this stage of training should be reviewed in 12 months' time, with a view that most of them should be caught up. If that's not the case, I think we're into a whole new ballgame, and that's where we will have to consider, well, what are the requirements to get an adequate workforce? What are the end products of our training programs? What do curriculum look like to make sure we have a workforce that is necessary and required by the service? So I don't think there's any immediate thoughts of all of us going and re-examining and reassessing the curricular requirements. But I think as this progresses, we will need to keep that under review and monitor it very closely, Tim.
Okay, thank you very much. I'm going to try and pick up some of the questions in the open part of the question and answer box. And again, really grateful for the panelists. They've dealt now with 30 questions as the session's been going along. But Nigel, I suppose just in principle for you, what does informed consent look like now? Should we be quoting local outcomes, national outcomes? Just what should be in that informed consent now? You're muted, Nigel.
I think we have to remember that the Bristol Heart scandal was a surgeon quoting national statistics which were nowhere near what that individual could provide themselves. So the problem is our statistics from 4 months ago may not apply at the moment. They may apply, but we just don't know that because of where we are at the moment. So you can give it to the patient as a sort of guideline, but you shouldn't give them false hope and expectation. That's what we can do now. And that's why continuing the audits, continuing the NJR, continuing the flap registry, continuing all of those pieces of work are absolutely vital. So we know what the outcomes are at the moment. The same with the August databases, looking at upper GI surgery and lower GI surgery. Because without that information, we really are just in a massive fog at the moment. So essentially what someone needs to do is think, okay, I'm going to do this procedure. This patient needs this operation. I think this is the most beneficial thing. What if I don't do the operation now? What if I wait for 3 months or 4 months until the situation's better? What will be the outcomes? And you have to explain that to the patient. Then you've got to go through the care pathway. That if, for example, they get a hematoma, if they get a wound infection, what happens? Because if someone develops a complication at home, it's very unlikely that they will be able to be swab negative, and therefore they have to go into a COVID positive site. Now that means that they won't be looked after by the original team. That may affect their outcome. They may end up having a very serious complication. So just think about the what ifs. What if this happens? What happens to that patient? And now with Montgomery, with material risks, each of those will be viewed as by the patient as a material risk. And if you don't know, say to the patient, at the moment, we genuinely don't know. And I think that the bottom line is, if I needed a hip replacement at the moment, which merciful heavens I don't, I would think I'm 64 years old, I probably wouldn't do that at the moment because I don't want to take that extra risk. And as with all of us, whenever we propose an operation to any of our patients, if it were you, would you do it at that time in that situation? And the answer may well be no, in which case you shouldn't really be persuading the patient to have the procedure. You can put the information, but they must make that decision for themselves.
There's a couple of things that I take from that. One is about you need to be prepared to quote the risk of not being treated.
Yep.
You've not mentioned about potentially undergoing other forms of therapy or treatment rather than open surgery. So presumably that has to be discussed again. And if I can just sort of challenge you on audit data, you span out then quite a lot of audits that have been undertaken. My experience of audit data is it often takes quite a long time to collect, and then an even longer time to analyse in any meaningful sort of way. So having genuine real-time audit data is a great challenge at the best of times, and that's coming from the Society of Cardiothoracic Surgery background, where there's quite a lot of experience dealing with that kind of audit data. What's your response to that?
I think it's again those situations, the unknown, that we might be fine, but we may not be fine. And so we do need to continue collecting the data, the cardiac data, the vascular data. It's terribly important, because otherwise we'll never know what the impact of this was. But to some extent, we are almost all of us experimental animals in this, because we have no idea what the outcomes are going to be for a lot of our procedures at the moment. We all think about to the moment the patient leaves the hospital, but actually that is only a very small part of that patient's pathway, very small part.
No, I agree with that. If I could just change emphasis really, I think to ask Ian, if you don't mind. I think it's quite apparent that you've been very successful in engaging with the local private providers into them helping to undertake NHS treatment. I just wondered if you could expand on your approach to that and why it has been so successful.
Thanks, Tim. Yeah, I think we have been very successful. I think we've probably been more successful than most people around the country have been. I guess I would say two things. One, a very clear need sort of slapped us in the face in Birmingham at the end of March and start of April. So it became very clear very quickly that unless we were successful at using alternative facilities, that we really would get very little work done. So there was an obvious need, and necessity is the mother of inventive practice, isn't it? And so we basically engaged early, we engaged very openly and very honestly, and collaborated. So rather than having 10 different conversations, we had one with all of the private providers. And from the start, my aim was to simply use as much of their capacity as we could. And we were successful in doing that. And I think that openness and that collaborative approach has been the secret of the success. And I think that comes back to the other bit about what we do next in terms of working with partners in primary care, in CCGs, et cetera, and potentially in extending the independent sector contract. Thank
you very much. Tracy, I wonder if I could turn to you next, really. It's just to talk to you about your wider surgical workforce and how you've approached this. Should they be working in both essentially a relatively cold COVID elective environments only, or should they be also participating in emergency care and potentially the COVID hot sites as well? What's your approach been as the medical director to the disposition of medical staff?
So we've tried to divide people up into teams and keep them broadly within that. It is difficult in terms of making sure that you're getting the best match between particular skills. And what is required. We've not seen the same level of need as Ian has, although we got up to double our ventilated capacity as well, but the numbers overall were much smaller. So within our sites, we have kept going. We've tried to just deploy people to where the need is most. And I suppose the point that I'd want to emphasize, and it really picks up on what Nigel was saying, is I think surgeons need to be really aware of what is going on in their wider local system and be prepared to step back a little bit from wanting to undertake activity if the time is not right. If you've got a little localized outbreak, that might be the time to just pause and think differently. And if you're not fortunate enough to have completely cold sites and then COVID sites, just be aware within your hospitals of where those outbreaks are and how staff are moving around and behaving. And we need to really emphasize the need for, that correct behavior at all times, not just in the public facing areas, I can't emphasize that enough, actually.
Okay, I think you see the time is now approaching 8 o'clock, but I just think I'm going to ask Rowan maybe to make a final comment, maybe Rowan, about what the college is doing to help support the trainees and their training at the moment. What can the college do, and what are we doing?
So, I think it's important the college has a voice. It certainly, it's got a very active trainees committee who are thinking about a lot of these issues. I think we have to ensure at multiple levels, and one of the points I was making again on the chat is the statutory education bodies are being vocal to trusts and health boards to just remember education and training. I think the colleges have a commitment, should have a commitment to do that. And I think the other aspect that's come up is what about all the workload being shifted out to private institutions and the risk of that taking training opportunities away from the next generation, the trainees coming through. And I think these are all really important points. I think the college has to be vocal in saying that as clinical services are remobilised and restarted, that we don't neglect and forget the trainees, because they are our future and we need to get them through their training programs and out into the workforce. But there are ways of doing that, and a lot of even the private institutions are recognised, have approval for training. So that's one aspect, but we then need to get the trainees there. And I know that causes pressure on rotas and staffing and working in two sites, and these are issues that will need a local solution. But I think the general message and the message from the college is we need to support trainees and we need to support their training in all these remobilisation efforts.
Rowan, thank you very much. I think as we're now just the back of 8, we don't want to take up more of people's time on what's a lovely sunny evening, sunny Monday evening here. We've had over 200 participants join the webinar. The panellists have answered 40 questions. I'm sorry about the 6 that are left open, and there's a couple of comments, interesting comments in the chat box, which I think Ian and Nigel will be dealing with. I think on behalf of all the participants, the people that have dialed in essentially to the webinar, and on behalf of the Royal College of Surgeons of Edinburgh, I'd like to thank our 4 participants. I've certainly learnt a lot and appreciate some of the issues and problems around the remobilisation and reconfiguration. So once again, thank you very much to all our panellists for giving up their Monday evenings to the college and the people that have dialed in. So if you don't mind, I'll bid you all a good night from me, and it's good night from them. So good night. Thank you very much. Oh, just one last thing. Sorry. Just to highlight, tomorrow evening there is another webinar with JCIE and ICBSE and the presidents of BOTA and ASSET tomorrow night at 7 o'clock, which is going to discuss examinations, access to examinations, when they're likely to occur, and any changes that may be occurring around the examination system. So that's John McGregor from JCIE and ICBSE, and BOTA and ASSET will be on the webinar tomorrow evening. So yet another 7 o'clock date with the college. So again, thank you very much to you all, and good night. Thank you.
Good night.